Thanks, everybody, and welcome to the Interoperability Roundtable. This is an open forum fostering conversations around interoperability. My name is Jake Tunney, Product Manager at LeapOrbit, and I'll be your MC today. And I'm happy to announce that you can now find us on Spotify. And today, we're joined by host David Finney, and we're usually joined by Mrinal Bhaskar. And unfortunately, Mrinal could not make it today. He's feeling a little under the weather. So I send best wishes to Mrinal and hope he feels better soon.
We're all taking our masks off and reintroducing ourselves to the bugs of the world, I think.
I guess so. So yeah, we'll hope that he feels better soon. LeapOrbit is the trusted innovation partner to many of the biggest market-leading health data networks, including CRISP, Manifest Medics, and Sync Health, as well as the policymakers who oversee them. We are currently working on improving the accuracy and accessibility of provider data with our product Convergent, Provider Directory API as a Service. Convergent also assists plans to comply with the CMS interoperability rule. And today we are joined by Julie Barnes, founder and principal at Maverick Health Policy. Julie is a healthcare policy expert with years of experience helping the private sector navigate federal government activities that impact the healthcare system. Ms. Barnes is a strategic advisor to organizations that need guidance about federal health policies and how to develop relationships with policymakers and influential advocacy organizations. Formerly a VP of Federal Strategy at Cambia Health Solutions, Ms. Barnes informs business strategy and investments in a myriad of healthcare areas, including health IT, data privacy and interoperability, value-based care, transparency, health insurance and new payment models, and federal health programs. And before we jump into our chat, just a reminder that we always encourage audience participation. So please comment your questions for us in the chat. And Julie, before we get into today, we spoke earlier about this, but I thought that since we're sort of taking a focus on the No Surprises Act, I thought it might be good for you to sort of give a high-level introduction of what even is the No Surprises Act.
Absolutely. Well, and happy Friday to you, Jake, and everybody joining us. I hope you all have plans to get out in the world, because that's what we're doing. I'm about to go on vacation, so I'm in a pretty good mood today. So and thanks for the introduction. You know, I always hope that when somebody introduces me, they make some stuff up, because it just doesn't sound that interesting. But you know, the short version of where I came from was Capitol Hill during the first round of health reform in the 90s, and then 10 years as a lawyer, and then I fell into full-time policy work. And now I'm just doing health information technology because there's just too much work to be done. So, and this is an example, right? The No Surprises Act turns out to not just be work for lawyers and more arbitration in the healthcare space. It also is a healthy amount of price transparency, which is really about data exchange. So here we are. I'm just going to give a brief snapshot of what happened back in December, when everyone was distracted by not only the pandemic, but the fallout from a general election. And lo and behold, in that lame duck in December 2020, Congress enacted and the president signed the No Surprises Act, which provides new federal consumer protections against surprise medical bills that are such a long-term pain point for everybody. So really the gist of that bill is to provide protections and hold consumers harmless from the cost of out-of-network medical bills that they didn't anticipate happening. So that starts really in January of 2022. That's when it's going to be illegal for providers to bill patients for anything more than the normal in-network cost-sharing stuff under a patient's insurance, in almost all scenarios where surprise out-of-network bills happen. So it's a big deal, and that's the sort of high-level and sort of most important part of the No Surprises Act. But we are going to start to see rulemaking, supposedly statutorily, in July, that will put some layers on not only the arbitration process that is anticipated by that surprise billing rule or surprise billing law, but also these price transparency provisions that I suspect, Jake, you want to ask me about now.
That's a good segue. I think so. So we spoke a bit planning this about sort of the elements that we wanted to cover today around No Surprises Act. And I think the first place that I'd like you to cover is around advanced EOBs, Julie. So maybe you could take a stab at how that interacts with the No Surprises Act.
Yeah, so this is causing a lot of consternation, as you might imagine, among health plans who are really my primary professional experience base. That client list of health plans is near and dear to my heart, just from life, but also now, and also the health IT vendors that love them. So that's sort of my space. And the advanced explanation of benefits is really an issue just in conceptually, because if you think about what that means, we all get these explanation of benefits that are these terrible pieces of paper with writing on them that make almost no sense to any regular human about medical services that you just received and how much you owe and how much you paid already and how much is going to happen, and it's just very sort of terrible way of communicating what's going on and navigating the healthcare situation that you're in. But beginning in 2022, the No Surprises Act says that consumers can request advance information about how services will be covered before they are provided, which sounds amazing, right? So for scheduled services, consumers can submit a request, and generally speaking, within 3 business days, according to the No Surprises Act, the health plan is supposed to give you written information, including whether the provider is in network and a good faith estimate of what the plan will pay and what your cost liability as the patient will be. And herein lies the rub. I'm laughing, it's not funny. I mean, thinking about what a good faith estimate is just a little mind-boggling. Mostly because, there isn't, I mean, when you have some treatments, there's an right? There's a pill that you pay for, or there's a, surgery, you're going to get. And so there's usually a couple of like objective truths about a treatment plan, right? That you can nail to a wall and say, this is definitely how much this costs based on your, deductible and copays and coinsurance and rules of your benefit package or whatever, it's X. And then there's everything else. Like, oh, we didn't know you had that, other underlying health condition, which completely changes the game. Or you get into, call it a surgery, and it's so much worse than they thought. Or you have an attendant trouble, and so they have to bring in some specialist to hurry up and do that. There's so many things that there is no way for any good faith operating health plan can possibly anticipate about what's going to happen. So there's just that. You're basically setting up people for an expectation that cannot be met. Crystal balls, health plans do not have. So at some level, I'm completely on board with the skepticism of how this is going to work. At another level, we all kind of need this, right? Like we've all been kind of, it's not like we all have some sort of great comfort with when we go to buy cars, that the ticket item, the sticker on the car is actually what you're paying. Like that's not a thing. But it's a little bit more commonsensical when you walk through all the attendant fees and stuff, right? Medical information is just hairy, especially because so much of the rub of this is in and out of network stuff, right? So you don't just have a doctor, usually to deal with. There's always attendant other people in the services space. whether that's other doctors or not doctor professionals or, whoever and whatever products, drugs. So it's so uncomfortable if you're a health plan, and especially if you're a health plan lawyer. As a former health plan lawyer, I'm like, oh my God, that the legal sort of disclaimer that needs to be written on these things is long. I mean, I would write a long one, and then I'd write another one. I'd start out with a legal disclaimer, and then I'd end it with a legal disclaimer, because it is over the top sort of scary to think about how you are trying hard to provide the right information to people, and you could completely screw that up. So, the advanced EOB thing, good idea. Wow, does that have terrible consequences? And again,
consequences. Yeah, I was going to say, terrible consequences if your job is to run a health plan. But it does sort of change the conversation, which I guess is the intent, right? From if there's a dispute or a conversation between a plan and a beneficiary, the argument is no longer, how could you have billed me so much? I had no idea, retrospectively. To, well, you said it was this much and it turned out to be this much. What changed? It's a small, it may seem like a small sort of shift in the dynamic of the relationship between a consumer and their health insurer, but it feels like a pretty big deal.
Oh, I think, look, it's a business game changer. And it's a business game changer, not just for health plans and their enrollees and therefore employers that have contracted for those insurance benefits, right?
Sure.
It is absolutely a game changer for the plan and provider, back and forth, right?
Yep.
In some ways, you can imagine how the blame would actually shift from health plans not being right about something to a provider who didn't, who either left the network or didn't say they were out of network on time for the notice to go out, or, it actually plans to, to charge a lot more than is the typical range, of that service charge. So, if I'm a person, which I am on some days, and I go to get, medical services, and I ask my plan, and they're like, we're gonna pay for this guy who's solely in network, but the anesthesiologist, which is typical, right, is out of network, and we really don't know how much they're going to charge. You might want to talk to them. Like we're gonna aim and fire for you on paying this, but whether or not they plan, to charge more than that, and how they plan to, there is a weird little part of the bill that basically says out of network providers can negotiate with people for charging up, and essentially balance billing, even though it's not a balance bill, a balance billing bill. So to me, it's like, it's the whole thing is to pull back the curtain, right? There's a reason why they call these price transparency moments, right? It is really about exposing how much things cost earlier so that people can deal, right? Yep. That's fantastic. It's going to be an interesting dynamic to see who sort of gets left holding the bag on who's to blame for how much things cost. Because notoriously that has been health plans for sure. And I kind of wonder if that isn't going to shift when people realize it's the surgeon or whoever that's just charging an astronomical amount for whatever.
Well, so there's another piece of that, which is it's one thing to give the consumer more insight into what things cost. It's another question about what will the impact of this law have on premiums and on the cost of services, right? That's, in my mind, maybe you probably have a much better hunch on this than me, but if you look at the administrative burden that is going to be borne by the plans and to some extent providers to comply with this statute, and then you also look at the arbitration structure, where it's not clear, what view arbitrators will take of the facts of, a particular case and what's an appropriate charge. I mean, do you think there's a chance that we could end up in a place, beyond 2022 where suddenly things are more expensive?
Oh, yeah. So there's a couple of different fallouts here, and probably some that I just can't even reasonably anticipate. But I mean, if you're a health plan and you're looking at this and you're thinking, okay, the main way that people get upset with a health plan is by not knowing that somebody was out of network. And it just opens it up to costs that you can't anticipate, right? So you are shoring up who's in and who's out and why, right? And then you're also trying to figure out quickly how much you're paying the out-of-network guys typically, right? Which is part of other bills and other regs anyway. But this is something for this. You want to get straight quick. I think it's going to streamline the heck out of negotiations. And really, and this is part of the point, this is part of the spirit of the policy, is commoditizing, the range of prices for these kinds of services. Just no question about it. That the object of the game will be to compete not on price, because a price should be whatever, it's typically called the usual and customary, but that's going to be like, what do you expect? Like, what do you expect it to be? What is it reasonable to expect something's going to be? And then everybody's going to sort of say, oh, I totally got my, joint replacement for blah, 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 And that narrative is not just going to be a water cooler narrative or over your backyard, fence narrative. It's going to be in the newspapers. Like, it's going to be out there. It's going to be in price comparison tools. Like it's going to be pretty quickly, right?
We know from, lots of research that there's a huge dispersion of costs for comparable services across providers, right? And those costs are not correlated with quality and outcomes. So, I mean, I think one of the objectives of this whole exercise is to try to squeeze that band down, right?
That's exactly right. That's
to
exactly
find a
right.
market price for a market service.
Well, exactly. And again, it's never that simple, right? It's never that simple with these things. Because that's why medicine is just different. It doesn't work like the general economy, because it's not an it. There is no it in medical services land. It's not, you don't buy a product. It's science that changes based on who you are and what you have wrong with you and all that. And the professional services that are provided, varies for good and bad reasons, right? So it's just a complicated area to regulate in this way. And yet this is really all about incentivizing, at least getting it down to a normal, range of prices for the stuff that you can. That's really what the No Surprises Bill is trying to do, in addition to not bankrupting people for having some terrible medical condition accidentally because they didn't know, right? They didn't know what they were getting into, so they couldn't, influence the decision making. So we're going to have educated consumers, but we're also going to have a streamlined industry, right? That is so interested in undercomplicating what is overly complicated now.
So we kind of touched on the need for price comparison tool, and that is a requirement within the Act. So Julie, can you speak to that requirement a bit more and how you're conceptualizing of how those will be put into practice?
How it will be put into practice. So you mean the advanced EOBs?
Or the price comparison tools.
Right. So I'm not sure we actually said out loud. There's three really price transparency provisions. One is advanced EOBs, one is price comparison tool, and then one is provider directories. So we're on number 2 now with the price comparison tool, and really the law says, and there's no rules yet. So that's the other thing we probably should have said in the beginning. There are no rules to go find. There's a bill. But like normal statutes, it doesn't really get down in the weeds. We have to wait for rules, which we're expecting to come out in July. We're expecting them to come out from CMS's CSIO, the one that runs the insurance part of the world for CMS. So one of those things is this price comparison tool where plans are going to have to create a navigation ability for people, either, well, actually it's both. It's online and over the phone, so that people can have a choice of how they find out, that compares the cost sharing for a specific item or service by any participating provider. So you can look online for that, but there's all sorts of complicating factors with this. So first of all, price comparison tools exist, but they don't exist, I think, in a way that's sort of a blanket truth about all the different places and prices that are available for certain services. So we're limited in our price comparison tools now based on a per plan sort of basis. And yet we have, sort of these interoperability rules that are about to extend all of that, right? So we're about to have a whole different set of data to rely on that will expand these tools and make them more useful. But we've also got hospital price estimator tools coming from the hospital price transparency rule, completely separate rule. So there's the No Surprises Act price comparison tool rule for plans, but there's already in place a requirement for hospitals to create a price estimator tool, which is, I just have to call out as sort of an initial sort of, okay, so we've got to coordinate that, because as you might imagine, health plans have to say the same thing that the hospital said about what something costs. And those two planets don't necessarily talk to each other all the time about everything. So that's going to have to change. It's going to be interesting.
I actually see this becoming another area where CMS might be really smart to nudge the the market towards sort of the API economy and sort of an ecosystem here. I mean, these are the types of complex data problems that, you know, technology companies might actually be able to step into and make sense of. Like, how do you pull data from a hospital and pull data from a carrier and marry those things into a reasonable estimate of what something might cost for someone, you know, based on all the inputs.
Look, so you just hit on something that I'm more and more passionate about all the time, which is we need our technology friends to come tell traditional healthcare players how to do this. Because as a traditional healthcare related, industry person, we don't know, right? The folks that have been in this for a while, that are consumer facing and totally get how to like swirl an immense amount of data into a navigatable, actionable situation. Like, Amazon is always thrown out as an idea, but really the ones that are in this space and focused on healthcare as an IT, vendor helper are the ones that are going to get this right. It is just something that's a huge growth opportunity for the right folks that know how to create not only the sort of data mining that's necessary here, but the algorithms to learn what people need next, which again is what Amazon's really so good at, is they figure out who you are and then they help you, with right. What you don't even know you needed help with. That's where this is going. But wow, we are I think so far out from that right now. But that's where this should end up. So everyone is in that uncomfortable culture shock situation with, what they have to do to even clean the data, to get it to where it's supposed to go, to get it to be in a tool that may or may not be good, is kind of where we're at now. But wow, that is clearly where this is headed, right?
Well, I agree. And I think, one of the discussions that we have when we talk with plans and even, state Medicaid agencies is you should try to stop looking at these rules through the lens of regulatory compliance. And I know, Julie, as an attorney, you'll probably say, oh, well, that'll never happen. But the internet is sort of littered with these web-based tools that, regulated industries, let's say health plans in this case, have sort of thrown up to check boxes. I think that the force behind a lot of this rulemaking from an IT perspective is data liquidity, right? Like the end goal is not to put up a price transparency widget that sits on your web page and checks the box and doesn't get touched for 8 more years until the next rulemaking comes along. Can you make your data liquid and available to the marketplace so that the marketplace can figure out how to make sense of it?
Well, and yeah, now you're in, thorough interoperability speak, right? Like, so that's really about the interoperability rules and figuring out how to create standardized data so that whatever you're sitting on can then be translated into a bigger pot for people to pull from. Which is
so maybe that's a good
the dumbest way I've ever said that before, but yeah, that translated, that's what happens.
Maybe that's a good segue to talk a little bit about the provider directory pieces of the law. I mean, I will say, I remember 3 years ago sitting with the Senate Health Committee staff talking about Support Act and the opioid epidemic, and for them, no surprises was sort of at the top of Senator Alexander's mind before he retires. And it was the thing that they wanted to get through that was at that time sort of standing in the way of the stuff we wanted to talk about, which was the opioid epidemic. And it didn't really dawn on me hearing, folks on the Hill talk about this bill, that this really was a health IT bill.
Oh yeah.
And as I've started to wrap my head around that, I see how it interlocks with the interoperability rule and TEFCA and other things. And in some ways, I think raises the bar significantly because it imposes requirements on really the whole market and not just the CMS regulated plans.
Well, that's yeah, amen. Look, I think everything comes back to health IT now. I mean, I everybody starts talking about one thing. I'm like, oh, that's so health IT, because it's about the data. It's about the information, right? It's about the information flow and who gets it. So almost no matter what you're talking about in the healthcare space, to me, it always comes back to this. It's like, who's got the information? How are you getting it there? How are you getting it to where it needs to go? So yeah, no surprises. Bill definitely has a healthy amount of new rules about how basically you can't bill patients for things they didn't know they were going to get billed for, and really creating a new arbitration process. So that part is successfully not about data. The rest of it's all about data, and really informs that first part, because you need the information about who's in and who's out, who's charging what, who what costs what, and who's paying for which piece of it in order to have the arbitration conversations. So yeah, it's all sitting on the back of the information and who has it. So back to your thought about provider directories. This is another huge and long-term pain point for everybody in the business. Health plans have always struggled to maintain and timely update accurate provider network directories, right? And so this bill, not for the first time, but really kind of solidifies the establishment of a verification process to update the provider directory at least every 90 days. So health plans are on the hook for responding to requests from people within 1 business day about whether a provider or facility is in network. And then that information becomes binding. So you heard what I said about the 90-day, verification part, but there's a 1-day turnaround. So in my mind, it's a 1-day rule. Like everyone that I talk to about this, even though it's an uncomfortable thing to say out loud to people trying to implement so many things at once, but as far as I'm concerned, health plans need to figure out by hook or by crook how to get information updated every single day. And to me, even these rules wouldn't matter for that being true. I was already saying that about the interoperability rule implementation, just because how do you answer people's questions properly about information, which includes cost sharing information in the interoperability rule? That's totally in the interoperability. It's like this, I feel like that's not celebrated enough. It's a serious hot potato. That in addition to patients getting all of their information out of their medical record according to what the health plans know, that plans are also on the hook for telling people how much their cost sharing is in the interoperability rule, having nothing to do with transparency and coverage rule, having nothing to do with the no surprises rule. That's already in there. So how do you do that? If you're a health plan and you're like, I have to answer this request. How do you do that if you don't have an updated provider directory? It's a non-starter.
Yep.
These turnaround times are ridiculously quick, and sort of understandably quick if you're writing these rules and you're thinking, what's the problem? It's electronic, just push the button, kind of thing.
Well, and understandably quick
you need
too.
the information behind it.
Yeah, I mean, I think understandably quick too, if you're writing this rule from the perspective of the patient, right? I mean, the patient has to make intelligent decisions about their care based on actionable information. So, you kind of end up at the turnaround times no matter what.
Yeah, no question. Look, I just, I mean, in my mind, to comply, there are a myriad of deadlines in these rules that are not necessarily coordinated and are at the very least confusing. If they can be sort of dealt with separately, okay. I just think if I were inside the health plan and I was trying to figure this out, I would just make a blanket truth. We are making it a term of our contract with our providers to let us know every single day if something changes. Every single day. You got a phone number, address, guy leaving your network or office or whatever, you tell us. There just has to be an automatic truth about that. And then there has to be, call it a new department if it doesn't already exist, a set of humans that are in charge of updating it every day. That's their job. Again, if I'm the lawyer, that's what I'm saying to my folks, my operational folks that need to be married with compliance. This is how we do this now.
Well, I agree. And I mean, maybe I'm giving away cool new business ideas, but we've been sort of spitballing around what does that look like for, let's say, a health system on the technology side, right? I mean, are there APIs that you could expose to the market that basically say, hey, we have a contract with you. You want to know what's changed since the last time you checked with our employee census or provider census. We'll send it right back to you. I mean, I think FHIR creates the structure to do that. And
right.
It's not a particularly difficult technology challenge. It's just not something that providers have ever done before.
Well, look, when you have an incentive like there is in the No Surprises Act, for plans to update this, because consumers who rely on incorrect information, are entitled to have in-network cost sharing.
Yeah.
Bum, 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 bum. Like, you know what I mean? That should come with a trumpet call. Like it absolutely means plans are going to do whatever they need to do to get that information updated. And you're going to have, it's going to be, again, a cultural shock and a struggle to create those relationships that are friendlier. Because I think the unfriendly ones are going to go south quick. I mean, as you might imagine, if a health plan can't rely on your information and they continually have to make up where you leave off, are you going to be part of that provider network for much longer? Like, I just don't see, how that goes well, right, under this scenario.
So I think most of your career with plans has been sort of the larger side of the market.
I would love if that were the case, because that's where the money is, but that's not true at all.
Okay.
I definitely was a health plan lawyer for the big boys, because it was a national litigation firm and we served nationals mostly. no, the policy dynamic, like right now, a client of mine is Alliance for Community Health Plans. So that includes Kaiser Perm, which is obviously national, and some of the bigger heads of state, like Geisinger, UPMC, but mostly community nonprofit health plans. So little places in Wisconsin, kind of thing.
So let's take them, like the ACAP plans, the smaller plans. I mean, we have we've spent a lot of time talking with small plans and specialty plans about the interoperability rule, and that it's when we think of the health insurance industry, we tend to think of these monolithic, enormous, Fortune 50 companies.
United Healthcare made news like 4 times this week.
Yeah, right, exactly.
Yeah,
I mean,
if they say something out loud, reporters write it down. It's kind of crazy.
But there's a long tail, right? And there's some really small plans out there, and they I think face a really different set of challenges trying to figure out how to comply with these rules.
Yeah.
It's going to drive more consolidation for sure.
Well, there's no question. There's no question. But I have to say, I've been very impressed with the tenacity of my smaller health plans that I hold near and dear, because they're really, I do like regional plans because they are closer not only to their provider network just by their very nature, because they're smaller and they're in like literally nearby, but they also happen to just be more sort of community type, thoughtful people in terms of their investment in more of the non-medical social community dynamics that surround naturally medical services. So I've been impressed with their interest and zeal to keep up, but they are not as well capitalized. It's hard. They don't have the internal resources, and then they also don't have the money lying around necessarily to hire big hairy external experts, right? So it's not easy.
It's really interesting. I mean, if you just take the patient access requirements of the interoperability rule in the sub-regulatory guidance that was put out, it estimated the implementation costs at between $700 and $2 million up front, and I think it's clear that those costs they do not scale to the size of a plan. So like that's a thorn on the side of a United. But when you look at these smaller plans, we have a really hard time just as an advisor helping them figure out how they're going to make this affordable.
Yeah, no, I feel that pain directly a lot, and I do think the rule is scalable in and of itself too. So in some ways, having a national set of plans and the enormous number of benefit packages that are in an Aetna or a United Healthcare or even an Anthem. It's mind-blowing the amount of data that they are going to have to swirl, and I do think it's going to streamline those contracts and benefit packages that are offered, because you can imagine like the spreadsheets on the spreadsheets about what employer group got this but didn't get that kind of world that creates these different pricing dynamics. It's just and so I think the smaller plans don't have that world of hurt as much, and so it is a little bit more attainable. But again, it kind of comes back to do you really have a super crack shot IT department in those smaller plans that can really handle the enormity of the tasks they're being at? The other thing that I've always sort of harped on about these interoperability rules and so on is that they were invented for providers because of all the money in high tech that was dumped into electronic medical record, and that cottage industry that grew up with Epic and Cerner and TheaneHealth and everybody else. That was a provider thing, and it's still a provider thing. 21st Century Cures and ONC and information blocking is all about providers and the health IT vendors that serve them. And medical records are based on professional truths about medical record keeping, which is not health plans. It's not. Health plans are supposed to be paying claims. If you're paying a claim, you don't necessarily care if you're just supposed to pay the thing because you agreed to pay the thing, because that's what you agreed to in the contract. If the thing is a lab test result and the lab test result is negative and falsely negative, as a health plan, do you care? I mean, you have to pay it, right? So claims databases are not super fun to look at because they aren't right necessarily. And nobody cared. Like, that wasn't a thing before. And now we are supposedly supposed to have this super clean, complete, awesome data that smacks of a medical health record keeping process, which was never the thing. So it is sort of, it's sort of crazy at some level that we're asking those smaller plans to suddenly get religion about how they're keeping their data, because we're using it for all sorts of other purposes, when that was never a question before. At the same time, I think it's good. I secretly think it's a really good thing. We all need to be much more conversant about what we're talking about, from payer to provider and back and forth, no matter how big or small. And if that means consolidation, then so be it. We just have to get this together.
Well, so I think that actually speaks to one of there have been some questions that have been coming in on the chat, and I wanted to take a chance to address some of them. I think what you were just saying speaks to one of the questions, which is maybe a different perspective on the challenges that plans have that you were just describing. Plans are not subject to information blocking rules, and so are there certain pieces of data that plans guard most closely, that see as sort of their secret sauce, their competitive advantage, that they're going to be very resistant to, making available to the market for competitive reasons or intellectual property protections or whatever? Or is that ship sailing?
Yeah, that's what I was going to say. You said it faster. Look, again, as the former healthcare litigator, I litigated non-contracting provider arguments about how much they should get paid, right? So this is a very sensitive and legitimately sensitive, I suppose. Look, I wear a health plan hat. I'll just be honest, and I just think it's such a sort of, it shocks me, and I'm once removed thoroughly from this conversation, but these are very carefully negotiated contracts in a lot of ways for good reason. The deal is health plans have the humans to offer to the providers as their patients, because they agreed to cover the services, right? Mm-hmm. So that the plans bring the people, and the providers agree to be cost effective about the whole thing and high quality, right? And so that's the give and pull. And depending on where someone is located, where a provider group is located, they may dominate that space and very legitimately have higher price point. And plans who need an adequate provider network might have to just deal, and then vice versa, right? So you got a super competitive area, and you've got a super competitive health plan that can negotiate, what is an overly reasonable price point, right? And so that's, just kind of as an American that believes in capitalism, it's kind of uncomfortable to take that away from the people who are good at it. And another, but then we've gone to an extreme where you have price ranges that are truly ridiculous, right? Like there's this thing that we all know we need in medical services, and we're all getting it for a completely different price point, right. 4 times, 5 times different from one another. Insane. That's insane. So this is hopefully going to normalize that process, but I do think the ship has sailed for plans, mostly because the hospital price transparency rule exists, and the negotiated rates are part of that hospital transparency rule. So regardless of whether health plans feel super strongly about this, it's over. At some level, the hospitals are supposed to be already publicly displaying those rates. So it might,
so if you
change and morph over time, but it's out there. It's no longer a conversation point, really.
Right. And to your point about, the assumptions that hospitals use to present cost, transparent cost information are different ones than the ones that plans use to do the same thing. Plans that feel very proprietary about this stuff are going to be left in a position where, all right, if you're not willing to share this data, the hospital's representation of the situation is the only one that's out there for folks to look at. And if you want to tell your side of the story, you're going to have to present your own numbers.
Well, and the way I think about it is it's just the new business truth. This happens, right? Policy drives business change, whether, the business industry appreciates it or not, which is why I'm a policy consultant. That's like my whole thing. No, really, you have to pay attention to them. So I don't think, look, I think the cat is out of the bag, or whatever metaphor analogy you want to use. It's over. So the question becomes, well, then how do you compete, right? And I think the big answer is, you compete a little bit on price. You always try to beat the other guy a little bit on price, but mostly you're offering the highest quality services you can find. And
Right.
so what's fantastic, and I'm being sarcastic, is we do not really have a national standard on what determines what high quality is. Yay. I mean, it's always so, painful to recognize, despite the fact that we've all worked on, accountability, pay for performance, whatever we want to call quality, records, quality methodology. It's just not fully baked. It's not over. It's not done. It's not remotely where it should be. We're even moving into this scary area about, I'm going to get hit for this, but the patient narrative conversation, the sort of, tell Yelp what you think about the restaurant is now becoming the new truth about how you rate your doctors. And I'm telling you, I hope my mother is not listening, but you should not ask my mother what she thinks about her doctors. Like, it will not be fair opinion. It's just, there are parameters that make sense for having, patient feedback, for sure. I'm not saying that there's not. It's just, we cannot base our sort of quality truths on that. There has to be a better and more all-encompassing standard of how we're rating healthcare services. We don't have it. It's just a mess.
I don't disagree with you. I think, part of why we've ended up in that position is because providers have been so guarded about their quality information, right? Like, there's been a vacuum, and it's not easy for someone to understand. Like, when my mom had a spinal fusion a couple of years ago, and she's looking at all of the spine surgeons in Baltimore, and there's what, like 13 hospitals in Baltimore City, so you got plenty to choose from. How do I figure out where the best ones are? And how do I figure out where the really bad ones are that I don't want operating on me? So where you end up in that vacuum, I think, is the Yelp stuff, because it's the only information that's available for consumers to make.
What's interesting about the No Surprises Act is they they get to negotiate fair prices based on how great the provider is. Sorry, I just thought it was funny. There's all kinds of criteria that you get to just, sort of make judgment calls about what the rate is. And one of them for the health plans is you get to say what you normally pay, for those services in the past 4 years, like in that region. Makes total sense. But what on the provider side, it basically says, well, if you're Johns Hopkins, you get more, and if you're not, it doesn't say that exactly, but that's what it says. It basically says if you're the man, you get the really good rates. I just thought it was interesting that they baked that right into the law, and mostly because the way these things typically go, having again been a former litigator, you submit what the usual and customary charges are with a range, but basically based on whatever you pay that is Medicare fee schedule plus, right? Because that's the sort of blanket truth for everybody. Can't do that. The No Surprises Act says you cannot use that as a basis for your your suggestion on what the reimbursement should be, which is a little mind blowing. I mean, lawyers everywhere are going, wait, what? How do we do that then? So that'll be an interesting day.
Interesting. Well, yeah, I mean, of course, Maryland has gone its own way on all of this, so Baltimore's not the best.
That's the
example.
other fun thing about the bill is that it does not preempt any state laws
Right.
that dictate what's already true about what you pay for, non-contracted. But, I have some familiarity with those laws, and they're not always straightforward. There's still a lot of wiggle room for what, there might be a formula, but what factors you plug into the formula are not, set in stone.
Right.
So there's always room for lawyers, work for lawyers.
Well, so maybe we can wrap this up with paint a picture of your vision of the future here. I mean, we're in 2025, and the regs have been written, and the sort of market dynamics have gelled around the arbitration process and some of these new requirements. What does that world look like?
It's a beautiful world. I think we're really going to be messy and uncomfortable for a while. There's just so many things that we don't have in place that need to be in place that are going to make things kind of terrible. I think for a while, I struggle to be anything other than negative about it, just because there are so many rules happening all at once that I think normally the healthcare industry would have been all over it and would have been, struggling through and not necessarily super happy about all of it. But we had a pandemic, and it just shifted right when these rules literally were promulgated in March 2020. I mean, you can't make that up, that's crazy that at the same time we literally started dealing with a global pandemic, we had these sea changing, operational truths for healthcare. So flash forward, here we are, and all these deadlines are hitting, and we are necessarily going, whoa, and it was hard anyway, because they were so sort of rapidly in succession, promulgated by the last administration, and they are going to keep going. Like Mickey Tribathy just can't stop talking about how TEFCA's coming any minute now. And we continue to layer on these things without, say, a patient matching standard in place, right? We don't have a national, we definitely are doing this authentication to make sure we're talking to the right human at the right time so we can push the records where they go. And then, price transparency is one thing without the streamlining of who's paying who what. At the same time, we don't have quality standards to apply so that the price points make more sense, right? Like, it's just, wow, and we don't, and apparently all at the same time, just for fun, we have a dynamic where Congress is scrutinizing big tech in a general, antitrust, anti-competitive sense, but also we're very suspicious of their big tech's ability to keep sensitive data private and secure. You've probably heard that rumor, right? So it's just going to be ugly until it settles into a little bit more of a norm. 5 years, Oh, P.S. We just, Senate just passed the U.S. Innovation and Competition Act. You might have seen that. Yep. $250 billion into, emerging technologies that are going to be thoroughly in the healthcare space. So a lot of science, a lot of AI, a lot of, swirling of the soup over there. So again, we're just kind of in this explosive time. And I welcome futurists to explain to me what's going to happen when, but I am not one of them. I'm just one of these people in the messy details now. And it's going to be a real struggle, and everybody's going to sort of kind of do what's expected of them until we get this right.
One sort of final observation on that. I totally agree with all of that. This feels to me like the most dynamic time since high tech. And in some ways, I think like it has a different quality to it. In the sort of early days after high tech, so much of that was, how are we going to stand up these big programs and sort of shovel money into the market? Here, you see the market really grappling with how it's going to transform itself to comply with, totally new regulatory structure.
Comply with, but then be competitive about it.
Sure.
Like, I think it's only going to be a hot minute before somebody realizes the provider directories not only need to have whatever the stuff is, demographic, boring information in it, but it's going to have attached star ratings, or attached Yelp narratives, right? Like, it's going to get interesting fast in terms of how do you differentiate yourself? How is your price comparison to a cooler,
Yep.
So it's yeah, whew, it's a lot.
Well, Jake, normally you're the one to make the shameless plug for our provider directory solution, but I think Julie just did it for you. So
Yeah, thanks, Julie.
you can drop the mic.
Yeah, well, thanks so much, Julie, for your time today. I learned a lot. I hope everyone else on the call did too. And yeah, thanks again for joining us. We'll have the recording up soon on Spotify and YouTube. And I hope to see everybody else at the next interoperability roundtable.
Thanks so much, Julie. Have a great vacation.
Thank you for letting me participate today.
For sure. Bye.
Bye.